What's one of the biggest lies women have been told about menopause?
It's probably two. One is that you have to have hot flushes, which you don't. And secondly, that it's a transition. It's just something we go through. You know, once our hormone levels are low, they are low forever, whether we have symptoms or not. And there are health risks associated with that. And this is more important than ever now because we're living so much longer as women. You know, 100 years ago, we died quite soon after our menopause. And so these people who talk about the transition, it's almost like women say, oh, I'm through my menopause because I don't have any more hot flushes. And you're like, hang on, you're not through it. You're still alive. Your hormone levels are low. Sometimes when people are older, have hormones, then they go, wow, do you know what? I've got more energy. I can think clearer. I can get out of bed in the morning without hobbling down the stairs. And I had no idea these symptoms were due to my hormones. So we're just sort of underserving women a lot, really, by misinformation.
Feeling confident in your skin is so much more than what you see in the mirror.
And how can you feel good? Well, that starts from within.
Welcome to the In Your Skin podcast. I'm Christy.
And I'm Anna. Join us each week as we sit down with world-leading experts and thought leaders to delve into the latest insights, groundbreaking research, and cutting-edge advancements in wellness, longevity, and beauty. Dr Louise Newson, it is so nice to have you on In Your Skin. It's an absolute pleasure. I have listened to a lot of podcasts that you've been on, but you've also got your own podcast. And I've actually found it really, really impactful coming away from those podcasts. I've actually sent a lot of those to all my girlfriends. A lot of my girlfriends are in their 30s and 40s. But not only my girlfriends, their husbands. And I said, you have to listen to this and also make sure your husband listens to this. I thought it was really important for them to listen to it as well. So it's been great to listen to you. So I'm so happy to have you on our podcast today. I just want to start firstly, a little bit about yourself, who you are and why you've become such a big advocate for menopause and women.
Yeah, well, thanks for inviting me. It's great to be here. I feel really sad actually because women have a disservice. They seem to not be allowed to choose to improve their future health with hormones, and it seems just so unfair. So I'm obviously white, educated, doctor, but I still struggle to get the dose and type of hormones that I need to keep me functioning as a doctor, mother, independent woman from my NHS GP. So it's no wonder that lots of other people are struggling. And it's the struggling and injustice of it all that keeps me really passionate to help as many women as possible. And I feel that my role is really to allow people to have education so they can make choices that are right for them. And sadly, globally, it's just not happening.
And why do you think that is, that it's not happening globally?
Oh, there's so many reasons. I think partly because it's women. Like, you know, history of women has been bad, right? We've always been neglected. We've, you know, been gaslit by lots of people. There's a lot of hierarchy and patriarchy in medicine. So people don't like changing the status quo. People don't like change. And there's a lot of misunderstanding. There's a huge misunderstanding about hormones, what the different types of hormones are, what they do in our body, how they work, and you know, what the different types of HRT are. So people, when you get scared, you retreat, don't you? So then you do less, and that's what's happening. So there's a massive problem with poor education for healthcare professionals and misunderstanding by women partners, like you say. So a lot of it is about poor knowledge, I think.
Yeah, like I was somebody who, so I'm turning 42 tomorrow actually, but turning 42
nice.
And the term perimenopause. So I'd heard of menopause, you know, for a long time really, and knew that that was going to be a moment in my life in time that you'll stop getting your period and
that's basically
it's done,
it. That's
you know. But now it's this word perimenopause is very much being spoken about a lot. I'm hearing it so much on social media, getting targeted a lot on social media. What can you tell us? Maybe let's just go to the basics. What is perimenopause? And then what is menopause?
I mean, if we get even more basic, you know, if we think about what is menopause, and, you know, I hate the words menopause and perimenopause because they don't actually tell you what's happening to your body. So menopause, if you look at the definition, it's a year since a woman's last period, which I find, for a couple of reasons, quite bad, because I don't want to be defined as the woman by my womb. I want to be defined by my brain and my intellect, really. And also, the other reason is a lot of women don't have periods. You know, if they've had a hysterectomy or if they use a Mirena coil or some types of contraception, they won't have periods. So then do they not become menopausal? And they wouldn't by that definition. So perimenopause, peri is just a medical term for around the time of. So this means something's happening around the time of the menopause. And again, that's not very helpful either. So if we really think what it is, well, we talk about hormones being a problem, but it's not just one hormone. And that's where there's confusion as well, because there's three hormones that we talk about. We talk about estrogen, but we actually talk about estradiol, which is a good form of estrogen that we produce naturally when we're younger. Then there's progesterone, and then there's testosterone. Now, these three hormones are made in the ovary, and they help regulate our periods. They help improve um, our fertility as women, but they do more than that because they go in the bloodstream and they affect every single cell in our body. But they're not just ovarian hormones. We make them in other tissues, other organs, but we also make them in our brains. So then I think we need to be more accurate and talk about, has this person got changing estradiol levels or changing progesterone or changing testosterone? Because then you're really explaining what's going on in this woman's body. And often when hormones start to decline, they decline in quite a chaotic way. So people have changes of hormones in this sort of, and it used to be described as a chaos time in the 1800s before they knew about hormones. And it really is, because one day you might feel fine, the next day you might feel absolutely overwhelmed. You might feel irritable, you might feel sad, you might have palpitations, and then the next day you feel fine again. And that's because the hormone levels are fluctuating. But I think it's really, really important to say what it is. And I have a real problem sometimes in medicine when we're just labeling people with a diagnosis. So, for example, if I said to you, oh, you've got a headache, well, why have you got a headache? Have you got a brain tumor or have you got migraine or are you just tired? And it's far more useful for me to tell you you have migraine than a headache, for example. So if we say, oh, you're perimenopausal, well, are you low in estrogen? Are you low in progesterone? Are you low in testosterone? Or are these symptoms due to something else? And that's where I think we need to get away by thinking of it as a period problem or a fertility problem, because it stops a lot of people getting help and treatment. And often it means that a lot of women are being misdiagnosed. And we know in, your country, my country, women are being diagnosed all the time as depression or anxiety or a personality disorder or unable to cope with their work. And actually it's related to their changing hormones.
But can you test for these things?
You can and you can't. And this is the problem, because our hormones fluctuate. So you might have a blood test one day and be absolutely fine and your blood test is normal. Another day it might be low. But also if you have a low testosterone level, that's not necessarily causing all your symptoms. But, there's this real sort of fixation with testing. We don't always do tests in medicine. So, for example, I have migraine. No one's done a blood test to diagnose migraine for me, or no one's done a brain scan. They've taken a really careful history. And so you talk to patients, and women are not stupid. Women can often understand what's going on because a lot of us have symptoms before our periods. So those symptoms where people feel a bit flat, a bit joyless, a bit irritable just before their periods, period comes, they feel better. Well, those are related to hormonal changes. And often the symptoms in perimenopause or menopause are very similar. So women say, do you know what, it feels very similar. And so let's listen to women more. Let's not gaslight them and say, no, your joint pain, your headaches, your dry skin, of course that won't be due to your hormones because you don't have a hot flush, which is what women are told up and down, all over the world, actually. So we don't always need a blood test in medicine. And if we do a blood test, it has to be taken in clinical context as well. And that's why just doing it on your own and not seeing someone who understands hormones, might be doing you a disservice.
But then do you get to a certain age? So if you are, or maybe we can talk about what age people start to become, if that's how you say it, perimenopausal, and what's sort of the youngest age you've seen?
Yes, so we're all different, aren't we? So everyone's experience is going to be different, but our ages will be different as well. The youngest person I saw has become menopausal at age 12. So her periods didn't arrive. She had what's called streak ovaries. So she just had a tiny bit of ovarian tissue which wasn't functioning. But it took her 10 years for someone to make a diagnosis, and then another 5 years until she saw me because people had given her the wrong type of hormones and she was really struggling. So she struggled at school. She couldn't go to university. So we know about 1 in 30 women under the age of 40 have an early menopause. But many of us don't realize what we're missing until we get it back. I started HRT when I was 45. I had my third child when I was 40. And it was only when I started testosterone and it started to work for me, I thought, gosh, I wish I'd started this 10 years ago. Because when I was 35, I was investigated for palpitations, and I was feeling really tired. I didn't really know what was going on. And I'm sure it was related to my hormones, but I didn't think, the doctors didn't think. So, we can be all ages. And that's where it's important to just everyone be aware of hormones, and that's why I created Balance app. So people can download it when they're young and start to look at their periods, but more importantly, look at their symptoms.
So is that app for people as soon as someone gets their period, they should probably download that so then they can track it and see the different changes versus people being told at 35, absolutely. That's when to start?
Yeah. I think, we're sort of changing the app a bit, so it's not known as a menopause app, it's really known as a women's app, because my oldest daughter has PMDD, premenstrual dysphoric disorder, and I only really realized it in COVID when we were living literally under the same roof for such a long period of time. And there were 3 days every month where she just felt joyless. She didn't want to pick up a trombone, she didn't want to communicate with us. She just said, what's the point of being here? I'm just I'm just existing. I'm not enjoying anything. I'm useless. I'm stupid. I'm not clever. There's no point me playing any music because I'm no good. And I was like, what? And we were all a bit low, weren't we, in COVID times? But then she'd suddenly feel better. Like she'd have a period and she'd feel fine again. So she's on some natural hormones because they're a lot safer than contraception. And she uses the same dose every day. And, she feels great. She feels fine. So she's lucky, or whatever, unlucky, depending on how you view me, but having me as her mother. But if she was tracking her symptoms with the app and seeing, we've just extended our symptom questionnaire, so there's 72 questions on it with different symptoms, she would then think, okay, that's why I'm getting cystitis, that's why I've had recurrent thrush, that's why I get palpitations, because otherwise it's very disjointed and fragmented. And sometimes in medicine, doctors work in silos. So you might see a cardiologist for your palpitations, you might see a dermatologist for your skin problems, a neurologist for your headaches, and no one's really thinking, hang on, these symptoms might all have the same underlying cause.
And I want to talk a little bit more about symptoms, because it is hard to determine what is caused by what. And I know when I was 34, actually having my second baby just after, I was experiencing all the symptoms that you talk about with perimenopause, but I also had gut issues. I was highly stressed. So it's like, what's the correlation? Is that the cause, or is the mold toxicity I had the cause? And then that's putting my hormones out. But am I in perimenopause? And so it's, what period, would you say, does it need to be a consistent symptom in order to say that is perimenopause?
I think we have to have, I think we have to have a lower threshold for thinking about hormones. So postpartum, after a baby, our hormones crash. So our hormones are so high, they're, levels 55 times higher than they are when we're, having natural periods. And then the baby comes in and they fall off a cliff. And I did it myself. I had low mood, I had vaginal dryness, I had cystitis, I felt exhausted, but I just thought, well, that's because I've just had a baby. And the third time, it was even worse. But I had night sweats, and everyone said, oh, it's because your milk's come in. I was like, what? I didn't even think it was related to hormones. So, sometimes we give people hormones just for the postpartum period. They're quite safe. They're just topping up some natural hormones. So women feel better. But that's a temporary thing. But when people have symptoms that are interfering with the quality of their lives, then it's important to see someone who understands, because I'm a general physician, I'm not a gynecologist. So I'm highly trained in trying to work out what other symptoms are caused by other diseases. Because of course, I don't want to blame everything on hormones and find that there's another condition that I'm missing. But sometimes, and often in medicine, we do what's called a therapeutic trial. So we might try medicine. If you had, I don't know, a sore big toe, I might give you some painkillers. And if they don't help, I might give you some different painkillers or see what else is going on. And we do that with hormones. I say to patients, I don't know how many of your symptoms are related to your hormones and how much related to other things that are going on in life. But I do know that some of them sound like they're hormonal, and hormones are really safe because they're the natural hormones. They're very low dose compared to, say, contraception. And we just try them for 3 months, and then we can do some blood tests to see if you're absorbing them. And if you feel better, then it's very likely that they'll be related to your hormones, you know. So it's not difficult medicine. The hardest thing, time and time again, is for women just to be believed and listened to, and that's the struggle.
Do you think the medical system is failing women in this space?
Yeah, totally. Totally. And I failed women for many years because I didn't have the knowledge. You know, I think back to doing rheumatology jobs and seeing women with autoimmune diseases, women with seronegative arthritis, women with dry eyes, and I was giving them other drugs. I didn't think about their hormones. I was doing a neurology job, seeing women with awful migraines, headaches, didn't think about hormones. Women into GP, recurrent urinary tract infections, women with total body pain, with burning mouth syndrome. Didn't even cross my mind because no one had taught me. So it's not really necessarily the doctor's fault, but actually it's just not fair because the number of women who go back and forth to doctors all the time, and now what's happening is that women often know more than their doctors, and some doctors find that really threatening, and then it becomes quite a hostile environment. And the number of messages I get, you know, all over the world, from women just saying, I don't know who to see. And that's really bad, isn't it?
Yeah, definitely.
What do you think we need to do to change that?
So we need to educate people properly in a very holistic way, and you know, we need to make sure that education is done by people without their own agenda. I don't do any work with pharmaceutical companies, but every menopause society over the world does get paid by pharmaceutical companies, and of course they say it's independent, but of course it's going to make a difference. And a lot of education is done by gynecologists. I have nothing wrong with gynecologists, but they are trained in the female reproductive tract. You know, I think we should be trained by people who understand the brain, the joints, the heart, every system in our body, because, you know, menopause affects every system in our body. We've got some people saying it's not a hormone deficiency. Well, what is it then? Because the hormones are low. We need to be thinking about how we not just improve symptoms, but we improve future health, because longevity is something that's very important. And I'm very interested in health span versus lifespan. Like, I don't really care the age I die. It's a journey to that age. You know, I don't want to be an old woman in my, you know, rocking in my chair and needing carers and being cooped up in a care home. I really want to be independent. And thinking about hormones is part of that journey. You know, I exercise well, I eat well, I don't drink alcohol, I don't smoke. I've made choices that are right for me as an individual. So I'm not here saying everybody has to take hormones or everyone has to do exercise, but they just need to know the benefits.
And do you think if you are taking care of yourself, those symptoms are reduced through that period?
No. And I have a real problem with this, because so many people say if people did better self-care, if they exercise, they wouldn't have symptoms. Now, yes, they might improve some symptoms for some women. But, you know, I've seen a myriad of women, like thousands of women over the last 10 years, who have done everything right, yet they've become very low in their mood. They've been sectioned in psychiatric hospitals. They've had such bad joint pain they can't get out of bed. You know, I know even in my experience, the only thing that I did differently, because I had such bad joint pain and lethargy, that I reduced the amount of yoga I did. So you could argue I should have done a bit more yoga, but I couldn't have a better diet. I couldn't stop drinking because I don't drink. I couldn't stop smoking because I don't smoke. Yes, I could sleep a bit better, but I was waking up in the night with intrusive thoughts. So because my hormone levels were low and awful palpitations. So, you know, I think it's more not fair on women. Like, if someone's got an underactive thyroid gland and they're tired, you don't say to women, well, let's just try and improve your exercise and then think about thyroxine. And this is sad for women, because women are then set up to fail. Of course, we should be looking at lifestyle, but we should do that whether we're menopausal or not, whether we're perimenopausal or not. Like, any age, we should be looking after ourselves. But somehow all the conversation is, you know, self-care and look after yourself and do this and be kind to yourself and take this supplement. And, you know, I don't think that's fair. And that's often because people have their own agenda or they want to sell us something.
And what's one of the biggest lies women have been told about menopause?
I think it's probably two. One is that you have to have hot flushes, which you don't. And secondly, that it's a transition. It's just something we go through. And, you know, once our hormone levels are low, they are low forever, whether we have symptoms or not. And there are health risks associated with that. And this is more important than ever now, because we're living so much longer as women. You know, 100 years ago, we died quite soon after our menopause. And so these people who talk about the transition, it's almost like women say, oh, I'm through my menopause because I don't have any more hot flushes. And you're like, hang on, you're not through it. You're still alive. Your hormone levels are low. And so then sometimes when people are older, have hormones, then they go, wow, do you know what? I've got more energy. I can think clearer. I can get out of bed in the morning without hobbling down the stairs. I had no idea these symptoms were due to my hormones. So we're just sort of underserving women a lot, really, by misinformation.
It sounds so scary, though. I'm sitting here going, "Oh my God, what can I do?"
Well, this is the thing. You see, I think, and I've been criticised a lot by different gynecologists saying she's scaring women about hormones because she talks about suicide, she talks about mental health. Like, not everyone's going to get awful symptoms, but those that do often can't be listened to. And actually,
sorry to stop you. What's the percentage of women getting those horrible symptoms?
So 1 in 6 women who come to our clinic have suicidal thoughts. They've thought about harming themselves and ending their lives. We're a specialist clinic, and some studies say it's about 1 in 10 women. Now, that you might say that's only 10%, but that's 10% of half the population at some stage. So, 90% of women won't. That's great. But actually, the medicine I practice is inclusive. I'm not excluding people because they have awful symptoms. But we know the commonest symptoms are the symptoms affecting our brains. So low mood, reduced concentration, irritability, fatigue, reduced libido, because it's, our hormones reduce and change in our brain. But there's no point worrying about something because you don't know what your experience is going to be like. You might hardly have any symptoms, but what you do need to know is whether you have symptoms or not, you've got an increased risk of inflammatory diseases like heart disease, osteoporosis, diabetes, and so forth. And some women say, okay, well, I'm just going to moderate my exercise. I'm going to increase, what my food choices are going to be better. I'm going to do all this stuff. I don't want hormones. That's fine, but just know there are risks of not taking hormones, which are actually more than the risks of taking hormones. But we've just been programmed that HRT is a failure medicine. You take it only if you're really bad, or only if you're really struggling, or only if you've tried everything else. And that just seems really unfair because we know there are health benefits of taking hormones, and the hormones we prescribe now are completely different to those that are given in the study that showed the breast cancer risk.
You do talk a lot about hormone replacement therapy. Can you kind of talk us through that?
Yeah.
Take us back to the basics and where it's all come from and where we're at now.
Yeah, for sure. So many years ago, even when we didn't know about hormones, in the early 1900s, they knew that when women had their ovaries removed and were young, they developed all these symptoms. And they thought, gosh, there must be something in the ovaries. So when they finally discovered hormones, they needed to commercialize them. They wanted to make money out of them. So gynecologists worked closely with scientists and pharmaceutical companies. So they then quickly marketed HRT, but it was all synthetic. So the estrogen was made from pregnant horses' urine because there's lots of hormones in pregnant horses' urine, not just estradiol, but lots of other hormones, but they made estrogen from that. And then they made a synthetic progesterone. So the chemical structure was very different to our natural progesterone. So it was a sort of man-made chemical that they called HRT. So it's similar to our own hormones, but different. They started to give it to women and they realized that women felt better. But they also found, even in the 1940s, that people's bones were stronger. The 1970s, they realized that we had less risk of heart disease, dementia, autoimmune diseases. And lots of people were like, this is amazing, this is so good. But over the years, they found that some people who took this type of hormones, if they didn't take progesterone, there was a small risk of cancer of the lining of the womb. And then this big study showed, there was a breast cancer risk, heart disease risk. But then when you unpick the evidence properly, all these studies have been done with the synthetic, unnatural forms of hormones. So they have this chemical structure is different. So the body doesn't respond to them the same way as natural hormones. The risks are incredibly small, even with those types of hormones. And we know the WHI study that came out in 2002, the Women's Health Initiative study, is the one that scared women away because there was a big media statements about everyone should come off their HRT. What they didn't say was that this risk of breast cancer wasn't statistically significant. They didn't say there was a 40% reduction in bowel cancer, which is what the study showed. They didn't show that women had low risk of osteoporosis, which is what the study showed. And they also didn't say that women who only took estrogen without this unnatural progesterone had a lower incidence of breast cancer. So there were good news in the study, but no one knew that. They just said, no, it's bad. But you fast forward now 23 years, people are still talking about this study. Whereas I don't prescribe hormones that are derived from pregnant horses' urine. I don't prescribe the unnatural progesterone. And what's really frustrating and confusing in my mind is that this unnatural progesterone that was used in this study, showing that the risks, is still used in contraception, but we don't seem to worry about that. We give young people contraception and say, oh, you've got a risk, but it's really low, don't worry about it, crack on. Whereas once you talk about HRT or MHT, hormone treatment, everyone gets scared. Whereas all we're doing is giving the natural hormones. It's replacing like for like. And, it's the safest thing I've prescribed in medicine, yet it has the most fear associated with it.
But why are they still so terrified to prescribe it?
I don't know. Well, I think also what happened was when they found this risk of cancer, it got reported to the medical press very quickly before it was analysed properly, before they realised it wasn't statistically significant. So the FDA, the MHRA over here, so the regulatory authorities for medicines, put like a warning on every single packet of hormones to say risk of breast cancer, risk of heart disease, risk of stroke, even vaginal hormones, which are really, really low dose, and even the natural hormones as well. And so therefore you open your packet and you see this risk of this list of risks. But then as a doctor, I prescribe hormones and it comes up with a warning, risk of. And so then people go, oh gosh, that's really scary. I don't want to put my patient at risk. But they don't understand the evidence because they haven't read it. They don't understand what's going on. And even the guidelines that come out, we've just had NICE guidance in the UK, came out a few months ago, but they didn't distinguish between using the pregnant horse's urine estrogen with the natural estrogen, or the synthetic progestogens with the natural progesterone. So it's like comparing chicken flavour crisps with roast chicken. I'm sure your listeners will understand it's quite different in our body.
Yeah.
And that's what's going on, and that's when we talk about the risks with synthetic hormones, the risks with contraception. It's because they are the chicken flavour crisps of hormones.
Yeah.
And lots of women are understanding that a lot quicker than doctors. I've spoken to a lot of doctors and they're like, oh, hang on, Louise, sorry, you're just, no, it's too much. I can't understand what you're talking about. And I was like, well, it's basic science.
If you're loving the conversations we're having on this podcast, you're going to love Olay's new short film, A Better Look. It actually made me teary the first time I saw it.
Yeah, me too. I watched it the other night and I actually got a little bit emotional. And if you haven't seen it, it follows three women as they stand in front of a mirror and share what they see. It starts with them focusing on the physical changes, the lines, the wrinkles, the tiredness, something we're a little bit guilty of.
Yep.
But then they shift perspective and see their strength, not flaws.
Yeah, I really love that message. It reminds them that their best version is the one standing in front of them. It's not some future fix. It's who you are right now.
And Olay's been backing that message with decades of science in skincare. With this film, they share a powerful message, encouraging women to change the way they see themselves in the mirror, from self-critique to self-celebration.
You can watch A Better Look on YouTube. Just search @OlayAUofficial or click the link in our show notes.
And please reach out to us with your thoughts. We'd love to hear what resonated with you most.
You're going to love it.
When would the best time to start taking HRT? And how can you go to your doctor if they say, no, I'm not going to prescribe it to you? Do you just keep going to different doctors? What's your advice?
Yeah. So really the studies have shown the earlier the better. And that's for two reasons, really. Firstly, because people feel better. And in medicine, we often go into medicine to help people feel better. But secondly, we know that there's increased bone turnover, there's increased inflammation in the body. So we want to reduce that to keep people healthier. So the earlier the better. The other thing is that hormones that we use, like they're very safe, but they only last the day we use them. So say if I, gave someone some hormones and it really wasn't any of their symptoms related to their hormones and they didn't feel better or they felt worse, they just stop their hormones. The next day they're out of their body. So it doesn't build up in their bodies. If you go and see somebody who says, no, you can't, then go and see someone else. It's very okay to see second, third, fourth opinion people. None of us mind as doctors to have another opinion because, most of us take hormones for life. It's a big decision And we want to get it right, because if you get denied treatment that you want, then it could affect your future health and day-to-day functioning as a person. And I feel very strongly as a doctor that I'm here to help patients. I'm here to be an advocate for them, but I'm not dictatorial. I won't say to women, you have to have A, B, C, or you can't have X, Y, Z. It's about what's right for them at the time that's right for them as well. So that's why it's important that patients, women, and their partners are armed with the right information that's right for them. So making their decisions before they go to the consultation, I think, is really important. And certainly I get a lot more out of my consultations when my patients are really knowledgeable and they've thought about what they want to do. And that's really important.
Yeah. What about, so I want to talk a little bit about the impact of going through perimenopause and menopause for women and what that could do to your relationships. When it comes to your mood and things like that, like what should we be looking out for? Because, and more so, what should we be telling our partners to look out for when it comes to our mood or the changes that we're going through?
So this is why it's so important for partners to be involved, and it can affect so many relationships and ruin so many relationships. You know, I've lost count the number of women who've told me that they've left their partner and they wish they hadn't actually when they feel better. But mood symptoms are very common, not just low mood, but irritability, anger, you know, having a really short fuse. And, you know, menopausal women have always been a butt of a joke, haven't they? Just, oh, ignore her, she's going through the change. Well, actually, don't ignore her, because it's really horrible. And, you know, I remember myself at times where I just turned into a devil. I didn't care that I was shouting at my children. I didn't care that I was shouting at my husband, because it was almost like my brain was taken over by someone else saying, it's fine, Louise, you can be as angry and horrible as you like. But I've got a very supportive husband. I've been with him for many years. But if I didn't, he would have gone, do you know what, Louise, I'm done with this. I can't, I've got my own job and life going on. And the way you're talking to the children now is disgusting. Can you just go? And that's what happens. Divorce rate increases around the time of perimenopause and menopause. And, you know, it's a misunderstanding often. And, you know, even when I was shouting at my husband, I had no idea what was going on with my hormones. He had no idea, because I didn't have the knowledge that I do now, and neither did he. But if he'd said to me, Louise, this is really out of kilter for you, that you're not normally like this. Have you downloaded Balance? Do you want me to try and let's talk things through? Let's see if we can get some help. Because, you know, but also libido reduces a lot in many women due to the hormones. And you know, in Britain we don't really talk about sex because we you know, all embarrassed, but it's important. You know, having libido, whether you've got a partner or not, is important. And
does it decrease with age anyway, libido?
Well, it can do, but then let's not just think it's an age-related thing. Why don't we think about hormones? And, you know, we know that testosterone is really good for improving libido, yet hardly anyone is able to have it prescribed for them. Whereas if I had reduced libido as a man, I can just go and buy some Viagra. I don't have to justify how bad my libido is. I can just get out my credit card. So we shouldn't be, you know, saying, oh, it's because you're old, it's because you're stressed, it's because you're this. Let women decide what their libidos or low libido is due to as well.
And how would you know if the loss of libido is due to, say, you know, I've been in a 16-year relationship and maybe a little bit bored instead of my hormones?
Yeah. I think, you know, again, let's let the women decide. It's very unusual to just have low libido and no other symptoms. So, you know, look at this long symptom tracker that's on Balance. And if you have other symptoms that have crept in, so you've also got reduced stamina, you've also got low mood, you also feel exhausted, you're not sleeping, you've got joint pain, it's probably related to your hormones. If you've just got low libido because you don't like your partner, then that's not going to be hormones, is it?
Oh, dear.
Women can work that out.
This is a personal thing.
Personal question.
Yeah, it's tricky. I think that's where probably most women fall into the unknown, because you don't feel like you can go and see a doctor if you just have a headache. You feel like they would say, oh, it's natural, just deal with it. And I know you've said that in the past.
No.
And it's a little bit, I don't know, for me, I'm like, I want to see a doctor if I feel like I've really got a problem, because they probably are going to dismiss it. So I think there is that real barrier at the moment.
Yeah, but then I think, you see, I think this is where we have to think about it differently. So I often compare it with raised blood pressure, because people can understand hypertension, okay? So hypertension, raised blood pressure increases as we age. We know that because our vascular system changes. Lots of people have no symptoms with raised blood pressure. Some people might have a headache, but lots of people have no symptoms. Yet as doctors, we monitor blood pressure. If it starts to go up and there's no other reason for it, then we'll give treatment. And we give that treatment to lower blood pressure, the medication, because we know from the studies that giving blood pressure treatments will reduce risk of a heart attack and stroke. Isn't that great? Really good. It's really made a difference. So if I am a menopausal woman, I have an increased risk of a heart attack and stroke compared to how I was before I had hormones. So why can't I make a decision that I want hormones to reduce my risk of a heart attack or stroke? Because we know it does. And actually, if you look at the studies for primary prevention, so to reduce the risk of a heart attack in women who've never had heart disease, and you compare the efficacy of hormones compared to a blood pressure lowering treatment, hormones come out top. So people have no problem if they have a raised blood pressure saying to the doctor, well, I've done my blood pressure at home a few times, it's not come down, it's raised, can we talk about blood pressure lowering treatment? But it somehow seems like a bit frivolous talking about hormones, a bit of a waste of their doctor's time. And that's the way that hormones have been portrayed by many people, including many doctors, saying it's just, a middle-class woman who wants to have nice skin and hair. And it's not. It's about us wanting to have our organs and our tissues functioning properly with these natural hormones that help.
So do most people you see, you would say, try HRT and see how it goes?
So women who come to our clinic come because they've been underserved by our National Health Service. They've come because they've been usually prescribed or offered antidepressants. They're wanting HRT and they're having a really difficult time to get it. So it's a cohort of women who they've made the decision themselves. But as a GP, if I wasn't running a menopause clinic, then it's about choice. It's the same with any other medication. And this is where people think that, some of the work I do, I'm forcing women to take hormones. I'm not, but we have to remember that globally 5% of menopausal women are prescribed hormones. Yet every single guideline says it's the first line treatment for the majority of women. Now, 5% is not the majority. So rather than worrying about those women who may or may not want to have hormones, let's think about many women who want them and can't get them. And they're putting their future health at risk, actually, and maybe their marriage, their jobs at risk because they're unable to get an evidence-based treatment.
Mm. And just moving on from that, and we were just talking about relationships being destroyed, I guess, would you say that also women's careers are being destroyed by menopause?
Yeah, absolutely. Absolutely. We know there's quite a few studies. We did one a while ago showing that about 10% of women give up their jobs because of their symptoms. And the most common symptoms are fatigue, memory problem, and low mood. So don't give us fans at work because it really probably won't help. But a lot of people aren't going for promotion. They're reducing their hours, which means they're reducing their pay, they're reducing their identity. A lot of us have worked really hard for our careers. And I know for sure I would not be working as a doctor if I wasn't taking hormones because I couldn't remember anything. I couldn't remember drug names and doses. Like that's too dangerous to risk my career by working without a memory. So lots of people are giving up their jobs. It's costing employers a fortune for sick leave. The number of women that are signed off sick, but often with, back pain, with migraines, with low mood, depression, anxiety. And again, people aren't always joining the dots thinking about hormones.
What could we do, or what could organisations do to support women going through perimenopause and menopause?
Well, the first thing is I don't think we should be talking about supporting women through perimenopause and menopause because I don't think we need to support people. We need to give them information so they can get treatment that's right for them. And there's a lot of talk, isn't there, about workplaces providing support. Well, if I had a broken leg, I don't want support for that broken leg. I want someone to help me get treatment so I can feel better, so I can carry on working. So the most important thing workplaces can do is give information and education. So there's awareness out there. So people are not being misunderstood, because a lot of women find it really hard to speak up. They find it really difficult to explain what's going on, or they might not know what's going on. And that's, I did an event for Apple a while ago, and it was a lovely story, but it will resonate, I'm sure, to many people. There was a man there who just said, "Oh, Dr. Newson, I just want to thank you, actually, because you really saved my my work colleagues, not just her life, but her job." And I was like, "Oh, okay, what happened?" He said, "Well, I've known her for years. We've worked together for 20 years, and there was something not right about her for the last few years. She kept going off sick. She was very withdrawn. She wasn't so sparky. And I didn't know what was going on. And then she became depressed and really withdrawn. And we were really worried about her mental health. And then your Balance app came out. And I read it and I was like, hang on, why don't you download this? See what's going on. I wonder if anything's related to your hormones." And she's now taking hormones because it was her choice. And he said, "It's amazing. She's back at work." And like, if I hadn't have known about Balance, I wouldn't have been able to advise her or just, support her in that way. And that's really, really important.
Yeah, it shows that it's not just women that have to deal with this. And that example is a great case, because it really is. It has to be probably taught at school. And that's one thing when it came to even thinking about menopause. I was like, my mum never spoke about it. My sisters never spoke about it. None of my friends. It's only this year that I started to learn a bit about it. I didn't even know menopause was one day. I just had no idea. I had no idea about any of it. And I'm 38 and I don't know if I should be embarrassed. But then I think, actually, no, probably a lot of people and a lot of women my age have absolutely no idea what is going on. And sometimes I just question, why haven't we been taught this from a young age at school? There's a lot of things that we should have been taught.
And it's still not taught enough, really.
And what message would you like men to get out of this conversation, if there was one clear call to action?
Think about hormones, but think about them not just for older women, and also think about them for themselves. About a third of men have low testosterone. So once they think about themselves, they'll think about others a bit more as well. And the symptoms of testosterone deficiency in men are the same as in women. So, just involve your partners, because it could work the other way. My husband takes testosterone. I helped him diagnose his testosterone deficiency because he was tired and irritable and just not the same as he used to be. But you don't notice it when it's yourself, because it comes on very gradually. So having this awareness about hormones, because then a lot of people have got daughters, so they can notice if they've got PMS or PMDD or postnatal depression, and then think about hormones. So it's not something that partners need to wait until their partner or their loved one is older. They should all have knowledge now, really.
Oh, that's so important. I mean, my husband recently, I said to him, obviously we're talking about doing this episode, and I said, have you had your hormones checked recently? And he's like, yeah, and they said it was normal, but he's definitely gone through periods, and I hope he doesn't mind me saying this, where he's definitely lost libido or, gone through moody times. He's turning 50 this year. And I'm like, well, go check your hormones. He says, yeah, the doctor said last time, which was a couple of years ago, that my hormones were normal. And I'm like, well, go check them again.
Try again.
But are they not doing the right tests?
Yeah.
Is that what's happening? Because I feel like that's probably a lot of men as well, or a lot of people.
I mean, yeah, a lot of women say to me, my hormone levels are normal, but then the computer system is set up to only show if testosterone levels are raised, for example. So I saw someone in my clinic earlier this week and her testosterone level is 0.4. Now, usually anything with a 0 in front is low, isn't it? So, but the computer said normal, and the doctor had just read the normal bit, but actually it's the number that's important, and obviously that was low. So you have to, and that's why just doing a blood test off the shelf through the internet without somebody interpreting it can be, misleading.
And where do you see this topic, or menopause and perimenopause, where do you see it being in 10 years?
Oh gosh.
Or where would you like to see it?
Yeah. I mean, I think sometimes things are going backwards because there's people really putting blockers on to women. But I think what is changing is women are understanding. So what I love in 10 years' time is that every woman who wants to have hormones can get them easily. Every woman who needs to be listened to is. Every woman who should be taken seriously is. I think if we could reduce some of the antidepressant prescribing for hormonal women and think about hormones more, that would be better. But important, it's just about choice. And I think if the women could choose the treatment they want and get it in their first or second consultation, then that would be really good.
Mm.
And sorry for my ignorance, when it comes to hormone replacement therapy, and you say that you're on it and you're on it daily, what does that entail? Is that a tablet? Is that what is that? Sorry.
No, so we give no, it's fine. Because there's these 3 hormones, we usually prescribe them separately because then we can really control the dose, because people are different, the dose that they need. So we give the estrogen as the estradiol, the good estrogen, and it's usually through the skin as a patch or a gel. There is a spray, but it doesn't really get very well absorbed. Sometimes we give tablets of pure estradiol, so that's very different to the synthetic estrogens. And then progesterone is usually as an oral capsule, or it can be given as a vaginal or rectal pessary, depending on the indications for the woman. And then the testosterone is usually a cream or a gel. And, you've got it as a licensed preparation in Australia as Androfem, but we can use the male testosterone off license for women. And again, through the skin is the natural testosterone. And then we sometimes prescribe vaginal hormones as well. So about a fifth of women who take HRT still have urinary symptoms or symptoms related to vaginal dryness and soreness. So then we give vaginal hormones as well as the systemic HRT.
And with testosterone, is if you just go to your GP and say, I've got a low libido, can you give me some testosterone? Will they do that? Do they have to do the tests and see that you've got low testosterone, or how does it work?
It really varies. So we usually do a baseline blood test, and it's usually low, but it's good to have that as a baseline. Some menopause societies say that women have to have what's called HSDD, hypoactive sexual desire disorder, which again is another label for women. And if you look at the criteria, it actually says women have to be severely psychologically distressed for at least 6 months before they can have this diagnosis. I feel really strongly that as a doctor, I shouldn't be letting someone be severely psychologically distressed with anything for at least 6 months. So, but the guidelines usually just say reduce sexual desire. But we know, and we've just published some data, but it's been around for years, that testosterone can improve mood, energy, concentration. It can really help with mental health symptoms. It can help with muscle and joint pains and headaches, because it's a hormone that goes all around our body and helps every cell to work. So again, a lot of people will try testosterone, and if it helps and it gets absorbed properly and their levels still within normal female range and they want to continue it, then it can be transformational for a lot of women. So again, it's this gatekeeping role that doctors seem to want to have to decide whether a woman can or can't or should or shouldn't have testosterone. Like, it's just a natural hormone. Everyone thinks we're all going to get beards and become really ill by taking our natural hormone. Like, it doesn't really make sense, does it?
No. It sounds like, there's so much to learn on this topic. And it sounds like your app, Balance, is a wealth of information and definitely a place where our listeners could go if they are really curious.
And a real starting point. I feel like some people just don't know where to start in a way. No. For me, I'm like getting to that point.
The app is, the app's free. It's always going to be free. So, and we're constantly uploading more information that's updated, that's relevant. So people, as you say, it's a good place to start. Do the symptoms. There's a community section on it, which is incredibly active. A lot of women are helping each other on that, which is really wonderful, actually, to read. And then obviously my website, drlouisenewson.co.uk, has lots of resources. I do a weekly YouTube, I do a weekly podcast, and there's lots and lots of info under the knowledge section. There's lots of information there as well.
That's great. That's great. Well, last question for you. We ask every guest this question, but what makes you feel confident in your skin?
Oh, do you know what? It's really weird. I'm not a very confident person. I'm a very weird person.
Really?
You don't come across like that.
Yeah. I know. But it's perceptions, right? I'm really not. I think the thing that makes me confident is doing headstands, because not many people do
Really?
headstands, and I do one most mornings. And so at the end of every yoga practice, I do a headstand, and I do yoga most mornings. And that I feel like, yes, I can do it. And and also it's like anything, I've done it for several years and I want to keep going, because I'd love to be in my 70s and still do headstands. And that's my kick-ass moment where I think I'm really confident here.
I love that.
Love that.
I love that. And
That's
also probably coming away from even just talking on podcasts or talking about this topic, you must feel like a sense of pride and getting the message out there. So I think you should feel confident in that as well.
Yeah.
Oh, you're kind, but no, I focus on the negative. So I focus on all the things I haven't done and all the things I want to do.
Oh.
Well,
No, well, you're doing a lot.
Yeah.
You are doing a lot. And we do appreciate you coming on the show today and sharing all those insights. And yeah, we'll leave in the show notes as well, all the information of where they can find the app and where they can find you as well.
Oh, well, thanks for inviting me. It's been good fun. Thank you.
Thank you. We hope you get your train.